Thank you. That was that was a real treat for me. I followed Dr. Chandra's work for a long time, and you're going to hear a lot of similarities in my comments, although at a somewhat different, pitched at a somewhat different level. The purpose of this panel was thinking about purposes of LHIs, and so my angle on this is to talk about how we might be designing indicators to address a system that is supposed to produce health and well-being. And I mean that in the most expansive sense, as we've heard already, that it's a qualitatively different thing to aspire to produce health as we commonly understand that. Nowadays it skews very heavily toward physical, maybe a little bit of mental health, but it's hard to hear that word in anything other than the biomedical industry that has evolved in the last decade or last century. Well-being is a much bigger concept, takes into many other dimensions of states of being, and when you bring those two words together, they mean a whole lot more together than they do one or another separately. Let's see. The big green thing. So this is a pretty straightforward fact, but it's the core of seeing our work as a system, is to recognize that whatever we understand our health and well-being to be, it depends on a system that has been designed long ago, and it's really not working nearly as well as it could. So the question is, how did that system get designed, and how are we in a position to redesign it? Right? We have to see ourselves within this system as people and organizations, and we have to believe that we have some sense of agency, some sense of a role as stewards of this sort of the common lives that we've created. For several decades now, we've been seeing the system that we have developed as one in disarray. And Paul Wiesner, back in the early 90s, was famous for coining the idea that we are not beset only by injuries and illnesses and disabilities. We actually have now systemic problems in the way that we have thought about and organized the resources to address health and well-being in the society. Chief of these is the hardening of the categories, this tension headache between prevention and treatment, and others that have perpetuated a kind of fragmentation. And the ballooning and the proliferation of the healthy people objectives is a symptom of that prevailing mindset of really focusing on analysis and separation and sort of narrow parsing of problems and then the resources and response to those problems. We can do this differently. There are other ways of doing it, and we have the IOM report that coined the term disarray asserted that the fundamental purpose was to assure the conditions in which people can be healthy. Even now, decades into it, we don't really have a good, clear understanding as a society of what those conditions are. What are we supposed to be assuring when we want to create opportunities for health and well-being as a people? To do that, we're going to have to look through a different kind of analytic lens, right? This is a more macroscopic problem. We don't need to see things that are smaller with a telescope. We don't need to bring things far away, closer. What we need to do is be able to link things together and see the broader pattern that we're a part of. And this is a significant challenge because our data systems, our structures, our policy arrangements are not really built for a macroscopic view. I would argue that's one of the challenges and opportunities before you as the LHI is there a way to cultivate a much more heuristic way of seeing the things that connect us around this project of improving the opportunities for health and well-being, and rather than descend into the history of all of those A to Z, disease, body part, population group, esoteric pieces, which are there and important. I don't mean to dismiss their relevance. It's just that we can easily be deceived by all of those details and miss the bigger story. My approach to these comments has been to just lift up a handful of design principles. The first of which is whatever you do, you have to counter the disarray that has captured the modern health and well-being enterprise. This is more damaging in my view than the actual epidemics that we face and the actual threats to our health and well-being is our inability to actually organize together agilely and effectively at different scales to be able to do this work. If we can't do that better, then we have a hard time addressing both ancient and very modern challenges. We're also beginning to differentiate in more systematic ways some of the practical work that's involved here. And I'll echo much of what we just heard and bring it into a somewhat different language that comes from the first brief that defined health and well-being for Healthy People 2030. There were really fundamentally two ways you could look at this issue. You can look at it at a personal level, how we as individuals think, feel, and function, how we evaluate our lives as a whole. That's the subjective dimension of this, and in some ways is still the acid test on whether progress is being made. People have to feel actually better, and think, feel, and function is the framework that was used in the Healthy People brief. The other way to look at this is on the surroundings, right? If people's health and well-being are going to change, one of the best things you could ever know is what's going on around them. If you wanted to predict in advance what a population of people would say about their health and well-being, it'd be great to know things about the services they receive in crisis, right? If anybody in adversity might need temporary help to regain or restore health and well-being, that's sort of a necessary element to avoid the real collapse of both health and well-being. And then there are these other conditions, vital conditions, that are really properties of people, places and institutions that we don't need temporarily, and not just some of us. Everybody, all the time, needs a defined list of conditions in order to have the chance to reach their full potential. The difference here is that personal characteristics rise and fall. Our evaluation of health and well-being can rise and fall through birth to death, but it's bounded by our lifespan. These vital conditions, and to some degree the infrastructure that delivers urgent services, that persists over generations. There are legacies of choices made in the past that we encounter on day one throughout our lives, and we confer to subsequent generations. So there's a lot of infrastructure that goes on in shaping what those conditions are and the urgent services that are part of it. This figure appeared in the brief for Healthy People 2030. I just want to take a minute to narrate the emphasis on it, because we're not just in the business of dealing with shaping these opportunities for health and well-being once at a time. This is a dynamic system. And so the chief dynamic is that we all, throughout life, populations experience threats to their health and well-being. And the principal response is to care for when people's health and well-being erodes. That dynamic of setting up the delivery of services when people are in adversity is really the epicenter of not just the healthcare delivery enterprise, but a lot of social services, and many other dimensions we'll name in a second. That dynamic is kind of qualitatively different. As pressure builds, there's only so much caring you can do. We're going to end up recognizing that there are conditions that either avert those harms or can help to safeguard people's well-being before it begins to erode. That dynamic is a different thing, and what we end up with is a kind of a over-reliance or a balance in the ways in which we use our resources and think about these things. So what we did, so that's kind of the figure that appeared in Healthy People 2030, heuristically defines a systemic approach that situates people and populations within the world that in some ways precedes them and will continue past their lifespan. That's a broad theory, and it's rendered as a simple cartoon. How do we make this as practical as possible? And that was our challenge when we tried to identify sort of the portfolio of things that people actually do, that actually invest in. I love the comment here, and you're going to see it echoed, of if you want to roll up your sleeves and actually stack the deck in favor of health and well-being, what are some of the things you might do, and see that as a portfolio of reasonable actions. So we constructed a sort of more operational view of this in this pie chart. And it's got two halves, right? There's the urgent service side, which are really with 6 big ticket items. These are the major things that people need when they need urgent help, right? It's acute care for illness or injury. It's some kind of addiction treatment, usually, criminal justice, environmental cleanup, homeless service, unemployment, and food assistance. Of course, we could spell out many more kinds, but these are the major big ticket items that people and whole subgroups of people sometimes depend on for their very lives and survival. The flip side of this are these vital conditions. And the good news here is, similarly, you can boil this list down to something pretty short. And there maybe isn't gospel on exactly what this is. This list of 7 is a lot like the list of 6 you just heard from Anita Chandra, and other frameworks have others. We, in doing this work, tried to identify language that was as practical and sort of plain spoken as possible, avoid euphemism, identify things that are normative. We cannot go through life without some basic needs for health and safety, right? Clean air, clean water, nutritious food, physical activity, sleep, routine healthcare goes on this list, right? In adversity, we might need an ER, but everybody all the time needs routine healthcare. So this is a differentiation, not just health versus social, health versus healthcare versus something like we call population health. This is differentiating those parts of healthcare delivery that we need in a crisis versus those parts of healthcare delivery that we need all the time. And then links it into the other major practical requirements that everybody depends on: lifelong learning, meaningful work and wealth, humane housing, a thriving environment, reliable transportation, and the sense of belonging and civic muscle that we each belong to a larger people, and we have a way to contribute to that. So there are many dimensions underneath these categories, but this expression of belonging and civic muscle, just as we heard a moment ago, is really infused in and shows up in every other category. When does the emergency ambulance show up at your house faster than mine? That's an expression of whose commitment we have versus others. Who gets, lifelong learning experiences assured from day one throughout adulthood? To what extent do we have humane housing for all people? This framework is built as a normative framework. Everything on this list is sort of designed to create normative expectations. Everybody who needs these things should get them, and any degree to which we fall short represents unfinished work. So this is not a sort of a collection of variables that we might do more or less better on. The goal here is 100% on every one of these things for all the people that need it. And any degree, any shortcoming represents the further challenge of our work our policy design. The good news is a framework like this can be pretty flexible. You can curate profiles of this, and many others, many folks have. You'll hear in a minute about the Well-Being in the Nation measurement framework. It's really easy to crosswalk, a group of measures into a dynamic theory that says, to what extent can we use these measures as a way to think and learn and act into the kind of the broader system that we're creating. So there's really no shortage of measurement options. The question is, how do we bring those measurement options into a framework that we can understand and act on? That part has been one of the shortcomings. This is just another example. You'll hear in a minute about the Well-Being in the Nation measurement framework. We did a little exercise to see if we could take these 7 vital conditions and map them into nothing but the county health ranking data. Relatively easy and straightforward. Sure, there's a few things you'd sharpen your pencil on and get better, but you can get very close to telling a story about this kind of systemic orientation by looking at nothing but the major indicators that are in the county health rankings. The good news is these things all turn out to be incredibly actionable too. We have repositories of evidence that have been accumulating for a long time, but it's mostly evidence about sort of a programmatic area. What are the 9 best ways to deal with asthma, or the 7 different ways of having a comprehensive tobacco program? We often approach our evidence base as an inventory of the programs and projects. The task of assuring health and well-being for a population can't be done on a transactional basis on programs and projects. It really has to be a progressive effort, and by that I mean a relentless effort, to assure conditions and bring more and more people into sort of the inclusive sphere of who enjoys those conditions and who doesn't. That's really the way of looking at this as a matter of equity. So 2 more design principles now, right? Use whatever data we've got to tell a larger story. It's got to be linked into that bigger story, hardwired into it. Otherwise, the dominant mental model of a transactional program, fragmented approach will be the thing that most people bring to this. So that has to come from somewhere. And we should inspire effort to fulfill these as widely shared norms. It's kind of frustrating that decades after knowing that our purpose is to assure conditions, we don't know what those are. This framework that I've enumerated, it's a kissing cousin to others like it, is really a step toward saying there are out loud conditions that we must be in the business of assuring. Anybody who doesn't get them represents the further work that we must do. I'll end with this last point. The Gallup Wellbeing Index has been tracking state and community level change for a long time. 2017 was really disappointing, right? This is the first year in a decade of measurement that there was no increase. Not one state had any measurable forward motion on this big, kind of measure. Many states fell backward. But if you look at that at a more micro level, at the metro regions, 186 metro regions, there is a different story, right? These metro scores don't always correlate with the state that they're part of or the nation that they're a part of. Locally driven efforts can really succeed even if the state environment is hostile, and vice versa. It becomes very hard sometimes for local efforts to succeed if there's a lot standing in the way. By that, my conclusion from this fact is that we really have to be able to tell a kind of a good news, bad news story. Celebrate progress where we see it, and also acknowledge that we face some pretty major, unprecedented threats that are defining the kind of the moment that we're in. So that's the last thing, is this measurement framework, even the microcosm of the few that you're going to lift up, will be used and should be used to mark success where we've had it and to confront the unfinished work, as it will always be in a perpetual story. So I will stop there.